Hi, I'm Janine Forsberg. I'm Director of Emergency Services at St. Joseph's Hospital in downtown Denver, Colorado. I chose a business plan for organizational change, and the title of my project is Workplace Violence Behavioral Health FTE Proposal. Who am I? I've been 20 years as an RN. I started out initially as a surgical intensive care unit at SICU nurse. I then moved to the emergency department. For 4 years, I was an infection preventionist while my mother was ill and I was taking care of her. And then I got back into the emergency department as the director of emergency services at Salina Regional Health Center in Salina, Kansas. I did that for 6 years, and then now for 2 years, I have been director of emergency services at St. Joseph's Hospital in Denver for almost 2 years. I moved here to be closer to my family and my grandbabies. Why I care? Workplace violence. After an episode of workplace violence, there can be an immediate and profound loss of life or physical or psychological repercussions felt by the victim as well as the victim's family, friends, and coworkers. There can also be loss of productivity and morale that sweeps through an organization after a violent incident. Every year, approximately 2 million people throughout the country are victims of non-fatal violence at the workplace, and that's mainly in healthcare. I've been a victim of workplace violence. My staff have been victims of workplace violence, and some of my staff have left healthcare because of the repercussions of what they had to go through. All of us in healthcare have an obligation to keep each other safe. The key stakeholders in my proposal are the patients' families, the patient's friends, the immediate staff, the ancillary staff, such as security, respiratory, the physicians, anyone and everyone throughout the hospital, administration, the hospital system, the community, and all healthcare workers. My proposed solution is a behavioral health FTE proposal, and this is to help with workplace violence. I propose a 3-tiered approach. The first is prevention, stop it before it happens, train staff in de-escalation techniques. We already have that in place at our facility. The second step is proactive response. If it happens, we need an aggressive prevention team, an APT, and a behavioral alert response team. Right now, we don't have that in place at our facility. And then recovery is the third step. After it happens, we need a critical incident response team, a CERT team, to go and debrief, talk about what went well, what could we have done differently, how can we prevent it from happening again. It's not safe for healthcare workers. According to P. Thompson in 2015, healthcare workers are 5 times more likely to be victims of workplace violence than in any other industry. 55.6% of emergency department ED nurses report physical and verbal violence, and 57.6% of ED nurses rate safety of their ED only a 5 out of 10. 1/3 of ED nurses consider leaving the ED because of violence. And it costs between $60,000 to $100,000 to replace an EDRN. Workplace violence is widespread and expensive. Hospitals spent in 2016 an estimated $2.7 billion in preparation and response to workplace violence. Research has shown that money spent is usually divided into 4 different categories: preparedness and prevention for public violence, post-incident public violence costs, preparedness and prevention for violence in healthcare facilities, and costs following a violent incident in the health facility. Let's talk about this 3-tiered approach. The 3-tiered approach mentioned earlier includes prevention. This tier focuses on education of associates, including recognizing warning signs of aggression and de-escalation techniques, and we currently have that in place. That's step 1. Step 2 would be a proactive response, and this tier focuses on the prevention of violence utilizing a proactive aggression prevention team, an APT, who responds to escalating situations that are not yet violent. This tier also provides for a behavior alert response, a BAR, which is an enhanced version of what we already have in place, and it's known as the Dr. Quick codes. And behavioral health staff responds to imminent or actual violence as it's unfolding. We are not able to implement this tier with current resources. Step 3, recovery. This tier focuses on the aftermath of events and provides for critical incident response team, a CERT team, who deploys to debrief with associates involved in serious safety events. There's 2 options on how much this will cost. What I'm proposing is a 1.8 FTE for behavioral health staff, each with a different cost attached. If we hire 2 licensed, master's leveled behavioral health providers for a 1.8 FTE at an average of $32.87 an hour, the annual estimated total cost would be $123,394. Or we could hire 1 unlicensed and 1 licensed master's level behavioral health provider for 1.8 FTE at an annual estimated total cost of $117,604. So let's compare the costs. If we spend $123,394 for 2 licensed master's level behavioral health providers for 1.8 FTE annually, that's not a bad price. In 2017, I lost 2 ED RNs after workplace violent incidents. They no longer could tolerate, not necessarily tolerate, but they could no longer they just were no longer able to work in the ED after they were attacked. This cost the ED close to $200,000 up to in finding another RN, hiring them, orienting them, and getting them on the floor. We had at St. Joe's Hospital last year in 2017, we had 21 reportable OSHA injury events. That cost our hospital approximately $210,000. So we're looking at $123,394 versus $410,000. What would you choose? It just makes sense to invest money on the front end, providing a proactive approach for prevention. It's an investment in the safety of our patients, their families, friends, and staff. My change agent is the CNO. She has her bachelor's in nursing and also a master's degree in organizational management, and she's now working on her DNP. She doesn't sit still long. She started her career 20 years ago as a bedside nurse. She has also held the positions of Director of Clinical Information Systems and Technology and Director of Critical Care Cardiovascular Neuroscience. Our proposed meeting is next week, April 18th at 9:30 in the morning. In summary, hospitals spent an estimated $2.7 billion in 2016 on workplace violence. Healthcare workers are 5 times more likely to be victims of workplace violence than in any other industry. 55.6% of emergency department ED nurses report physical and verbal violence. 57.6% of ED nurses rate safety if their ED is only 5 out of 10. And 1 out of 3 ED nurses consider leaving the ED because of violence. Investing money on the front end is a proactive approach for prevention. It's an investment in the safety of our patients, their families, friends, and staff. $193,394 versus $410,000. It makes sense to spend the money up front. Overall, how much is the safety of healthcare workers worth? One thing noted is since 2017, so far in 2018, our workplace violence incident reporting rate is up 198% for our hospital alone. We've already had 157 reports of workplace violence already for 2018. We have to think about keeping our workers safe. Please consider this option for a business proposal for organizational change. Thank you.